Welcome to Implicit Bias Awareness Training for Healthcare Professionals. Healthcare professionals enter clinical practice committed to equitable, patient-centered care. Yet a growing body of evidence shows that unconscious associations, known as implicit biases, shape clinical decision-making in ways that feed persistent health disparities across racial, ethnic, gender, weight, disability, and age dimensions. These biases work outside conscious awareness. They influence judgment at every stage of a clinical encounter, from initial triage and diagnostic reasoning to pain assessment, treatment recommendations, and patient communication. The scope of this problem is significant. A population-level analysis of more than 1.5 million responses from the Harvard Project Implicit database found that both physicians and non-physician healthcare workers showed measurable, implicit anti-Black prejudice. Among non-physician healthcare workers, including physical therapists, occupational therapists, and nurses, this bias remained significantly elevated even after controlling for demographic characteristics. Implicit weight bias affects a majority of healthcare professionals, with combined research evidence showing moderate to strong levels of implicit weight bias. Implicit disability bias persists among the vast majority of healthcare providers. And unlike implicit racial attitudes, which have shown gradual improvement over the past decade, implicit attitudes toward body weight, disability, and age have shown no long-term change toward neutrality. Here's the thing: implicit bias doesn't require prejudicial intent. The dual process model of cognition distinguishes between rapid automatic processing, known as System 1, and slower deliberative reasoning, known as System 2. Under the conditions that define modern healthcare practice, including cognitive load, time pressure, fatigue, and clinical ambiguity, clinicians rely more heavily on System 1 processing. System 1 draws on learned associations and heuristics or mental shortcuts that may include stereotypes about patient groups. This creates a systematic vulnerability. The very conditions under which clinicians most need accurate, individualized judgment are the conditions under which implicit biases exert their greatest influence. This course examines the current evidence on implicit bias in healthcare, its measurable impact on patient care, and the individual and organizational strategies supported by research for reducing its effects. The 5 modules progress from foundational concepts in measurement science through clinical impact, communication frameworks, and evidence-based mitigation strategies, ending with clinical case studies that integrate course concepts into the practice context of physical therapy, occupational therapy, and nursing. Upon completion of this course, you'll be able to define implicit bias and its relationship to dual-process cognitive theory. You'll also be able to recognize the contextual factors that amplify implicit bias during patient encounters. Beyond that, you'll be equipped to identify how implicit bias contributes to disparities in healthcare delivery and outcomes. Building on that foundation, you'll be able to explain the distinctions between cultural competence and cultural humility in clinical practice. And finally, you'll be able to describe evidence-based strategies for reducing the impact of implicit bias on patient care. Let's begin Module 1 by establishing what implicit bias actually is. Implicit bias refers to the attitudes, stereotypes, and associations that operate outside conscious awareness and influence judgment, decision-making, and behavior without deliberate intent. Unlike explicit biases, which individuals can consciously report and regulate, implicit biases are activated automatically when a person encounters cues associated with a social group. That could be a patient's name, appearance, accent, body habitus, that is, body type and build, or neighborhood of residence. These associations develop through repeated exposure to cultural messages, media representations, clinical training narratives, and personal experiences, becoming deeply embedded in cognitive architecture over time. The theoretical framework most commonly used to explain how implicit bias affects clinical reasoning is dual process theory. Type 1, or System 1, processing is fast, automatic, and effortless. It's the cognitive mode that enables a clinician to recognize a classic presentation of myocardial infarction or heart attack within seconds, or to perform a well-rehearsed physical examination technique without conscious deliberation. Type 2, or System 2, processing is slow, deliberative, and resource-intensive. It's the mode engaged when a clinician carefully weighs differential diagnoses for an ambiguous presentation, or decides whether to deviate from a standard treatment protocol. Both systems operate simultaneously, with System 2 monitoring and sometimes overriding System 1 outputs when sufficient cognitive resources are available. Any factor that degrades System 2 capacity shifts decision-making toward heuristic-driven System 1 processing, making it more likely that implicit stereotypes will influence clinical judgments. Because healthcare environments routinely subject clinicians to cognitive load, time pressure, interruptions, emotional strain, and sleep deprivation, clinical practice creates systematic conditions under which implicit biases are most likely to affect care. The key insight for healthcare professionals is this: implicit bias activation isn't a character flaw. It's a predictable consequence of how the human brain processes information under conditions of limited cognitive bandwidth. It's also important to understand that implicit bias isn't synonymous with racism, prejudice, or moral failing. A scoping review of 81 studies on unconscious bias among health professionals found that implicit bias is prevalent across all demographic groups of clinicians, including those who explicitly endorse egalitarian values. The dissociation between implicit and explicit attitudes is well documented. For socially sensitive topics like race, the correlation between self-report measures and implicit measures is typically weak, meaning the statistical overlap between conscious beliefs and automatic associations is quite small, far less than most people would assume. That reflects a meaningful gap between what clinicians consciously endorse and their automatic associations. So professionals who are genuinely committed to equitable care may still harbor implicit associations that influence their clinical behavior in ways they don't recognize. Now that we've established the theoretical foundations of implicit bias, let's turn to how it's measured. The Implicit Association Test, or IAT, is the dominant measurement tool in healthcare bias research. It measures the strength of automatic associations between target concepts, such as black and white faces, and evaluative attributes, such as pleasant and unpleasant, by comparing response latencies, that is, reaction times, across sorting tasks. The scoring system produces a numerical result that captures both the direction and the strength of a person's automatic preference. Established benchmarks are then used to classify each individual's result, indicating whether that person shows a slight, moderate, or strong automatic preference for one group over another, providing a standardized way to interpret the magnitude of the measured association. In 2022, a consensus document of 21 best research practices for IAT use was published, endorsed by more than 90% of expert respondents, covering how test materials should be selected, how results should be scored, and how findings should be reported. The IAT's measurement properties, however, present significant limitations that constrain its appropriate use. Test-retest reliability, meaning the consistency of scores when the same individual takes the test on separate occasions, is moderate at best for single administrations. Scoring consistency falls well below the levels seen with explicit self-report measures, meaning that the IAT produces noticeably less stable results from one sitting to the next than questionnaires that directly ask people about their attitudes. Roughly 50% of what a single IAT score captures reflects actual individual differences, and roughly 50% represents measurement noise. A single administration simply isn't adequate to estimate trait-level bias for any individual clinician. Alternative measures have been developed to address specific IAT limitations. The brief IAT cuts administration time from approximately 15 minutes to 2 minutes while maintaining comparable measurement quality, and the single-category IAT allows measurement of attitudes toward a single group without requiring a contrasting category. The predictive validity of IAT scores for discriminatory behavior remains actively debated, with the field divided into roughly 3 positions. The most methodologically rigorous investigation was a 2026 adversarial collaboration, a study design in which researchers from opposing camps jointly investigate the question, involving 2,114 participants. Using multiple advanced statistical approaches designed to test the relationship from every reasonable angle, the study found that implicit measures added only a small but real contribution to predicting discriminatory behavior over and above what people's own self-reports already captured. Self-report measures were far more powerful predictors, accounting for roughly 45% of the variation in discriminatory behavior. Implicit measures were somewhat better at predicting biased behavior among participants with lower executive function, that is, the cognitive processes governing attention, decision-making, and impulse control, and lower motivation to control prejudice. Those are precisely the conditions of cognitive load, time pressure, and fatigue that characterize high-stress clinical environments. All collaborators agreed that results lend themselves to both relatively optimistic and pessimistic interpretations. A critical nuance from healthcare-specific research is that implicit bias more reliably predicts patient-provider communication quality, including verbal dominance, patient-centeredness, and patient ratings of interpersonal care, than it predicts treatment recommendations where the evidence is mixed. Given these limitations, the current evidence doesn't support using the IAT as a diagnostic tool for individual clinicians. The field is moving from individual attitude measurement towards skills-based behavioral assessment. The Relate rating scale, which stands for respect, empathize, listen, ask, talk, engage, represents the first rigorously validated tool for evaluating bias-mitigating communication. It demonstrated good agreement across independent evaluators, meaning that different raters watching the same clinical encounter reached consistent conclusions about the trainee's performance on the majority of assessed items. It also confirmed that the scale genuinely measures the communication skills it claims to assess, with items within each skill domain hanging together reliably and consistently capturing the same underlying competency. These results were established when standardized patients evaluated 123 clinical trainees in simulated encounters with diverse patient populations. This skills-based approach is complemented by verbal procedures, which are personalized statements clinicians can use to restore rapport when implicit bias has affected an encounter. Research found that 91.3% of developed verbal procedures contained helpful elements. Together, these tools emphasize observable behavioral competencies rather than internal attitude measurement. Let's now look at how widespread implicit bias actually is among healthcare professionals. The scope of implicit bias extends across multiple domains, with prevalence data drawn from studies involving hundreds of thousands to millions of participants. Starting with racial and ethnic bias. The largest healthcare-specific dataset analyzed more than 1.5 million responses from the Harvard Project Implicit database collected between 2007 and 2019. It found that both physicians and non-physician healthcare workers showed implicit anti-Black prejudice. After controlling for demographics including age, sex, race, education, and political orientation, the physician general population difference became non-significant, suggesting that demographic composition explained their elevated raw scores. For non-physician healthcare workers, a category that includes physical therapists, occupational therapists, nurses, and allied health staff, implicit anti-Black bias remains significantly elevated, even after accounting for all measured demographic factors, a finding that was statistically robust and almost certainly not due to chance. White non-physician healthcare workers showed the highest levels of anti-Black prejudice of any subgroup examined. A scoping review confirmed that of 81 implicit bias studies in healthcare, 51 focused on physicians and 20 on nurses, with physical therapists and occupational therapists rarely included. That's a critical evidence gap given that these professionals spend substantial time with patients in therapeutic relationships where implicit bias can influence treatment decisions and patient engagement. Turning to weight bias. Implicit weight bias is prevalent among healthcare professionals at levels comparable to the general population. An analysis of more than 1 million project implicit responses from 2006 to 2022 confirmed that implicit and explicit weight bias persist among healthcare workers, with diagnosing and treating practitioners expressing more explicit bias than other professional groups. Combined data from 41 studies found a moderate and consistent level of implicit weight bias among healthcare professionals, with the overall pattern of findings robust across the body of research and almost certainly reflecting a real phenomenon rather than chance variation. Among 4,732 first-year medical students surveyed in the Medical Student Changes study, 74% showed implicit weight bias comparable to bias against racial minorities. Next, let's look at disability bias. Analysis of more than 630,000 respondents from the Disability Attitudes IAT, collected between 2006 and 2021, found that nurses had more negative implicit attitudes toward people with disabilities than other groups, despite having more positive explicit attitudes. That pattern is described as aversive ableism, which means holding negative implicit attitudes while simultaneously expressing positive explicit ones. In a separate analysis of 25,006 healthcare providers, the average implicit bias score reflected a moderate automatic preference for non-disabled people. In a longitudinal study of 67 occupational therapy students, explicit attitudes improved during education, but implicit attitudes didn't change, and 68% were implicitly ableist at graduation. Implicit disability bias didn't improve over the 15-year observation period for any professional group, with bias levels remaining stubbornly in the moderate range throughout the entire observation window. Age bias among healthcare professionals is the most under-investigated domain. No large-scale study has specifically measured implicit age bias via IAT among practicing healthcare professionals, with reported results in the 2022 to 2026 window. An assessment of 308 Chinese nursing undergraduates using the single-category IAT found a moderate level of negative implicit aging stereotypes, though individual scores varied considerably. In that study, intergroup anxiety, which refers to anxiety experienced during interactions with members of a different social group, mediated the relationship between professional commitment and implicit stereotypes. An analysis of 8,680 Dutch participants over 12 years found that men showed higher implicit ageism than women, with no significant relationship between participant age and implicit ageism, and no change over the observation period. These findings are especially relevant for rehabilitation professionals who frequently serve older adults with chronic conditions. Looking at temporal trends, the most concerning pattern across domains is the divergence between biases that are improving and those that aren't. Analysis of more than 7.1 million IAT tests from the U.S. population between 2007 and 2020 found that implicit racial attitudes decreased 26% toward neutrality over 14 years, a trend consistent across demographic groups and confirmed internationally across 1.4 million participants in 33 countries. In stark contrast, implicit attitudes toward body weight, disability, and age showed little to no long-term change over the same period despite decreasing explicit attitudes in all domains. This suggests that the societal-level mechanisms driving implicit attitude change are domain-specific rather than reflecting a general egalitarian trend, and that weight, disability, and age biases may require targeted intervention strategies, distinct from those that have worked for racial attitudes. Now let's examine the conditions under which implicit biases are most likely to influence clinical decisions. Research has identified specific environmental and psychological conditions that act as contextual amplifiers of bias activation. These aren't just theoretical concerns. They describe the routine conditions of contemporary healthcare practice. Cognitive load increases reliance on stereotypic associations by depleting the System 2 resources needed to override automatic processing. Experimental research demonstrated a three-way interaction between cognitive load, provider gender, and patient race in opioid prescribing decisions for chronic low back pain. Under high cognitive load, male physicians were less likely to prescribe opioids for black versus white patients, 12.5% versus 30.0%, while the pattern reversed under low cognitive load. This finding illustrates that bias doesn't emerge from stable racist attitudes, but from the interaction between cognitive conditions and implicit associations. Time pressure similarly shifts clinicians towards System 1 processing. Research shows that stereotype application, not activation, is time-dependent. Stereotypes are activated automatically regardless of time available, but with sufficient time, individuals can inhibit the application of activated stereotypes to judgment and behavior. Under time constraints, this inhibition fails, and stereotypes influence clinical decisions more strongly. Burnout and emotional exhaustion have an independent dose-response relationship with implicit racial bias among resident physicians. Each unit increase in depersonalization was associated with a measurable increase in implicit racial bias, a finding that held consistently across the sample and was almost certainly not due to chance, demonstrating a clear dose-response pattern linking burnout severity to bias levels. Burnout was independently associated with greater explicit racial bias as well. Emergency department overcrowding produces similar effects through objective environmental load rather than subjective perception. Residents caring for more than 10 patients during a shift showed a meaningful increase in implicit bias, with the size of this increase falling in the medium range, large enough to be clinically relevant and reliably detected across the study sample. Higher overcrowding scores were associated with increased bias. Self-reported fatigue and busyness were not independently associated with IAT changes, suggesting that objective environmental demands matter more than clinicians' self-assessment of their cognitive state. Sleep deprivation compounds these effects. Research shows that chronic sleep restriction increases negative implicit biases that were undetectable when participants were rested, suggesting that sleep restriction may unmask biases otherwise inhibited in a rested state. Clinical ambiguity creates reliance on group-level priors when individual-level information is insufficient. Research shows that patient race and clinical ambiguity interact, with treatment decisions varying as a function of ambiguity for white but not black patients. So what does all this mean in practice? The conditions most commonly invoked as unavoidable features of healthcare, being busy, tired, pressed for time, and managing complex patients, are the very conditions that amplify the influence of implicit bias on clinical judgment. Now that we've covered the foundations of implicit bias, what it is, how it develops through dual-process cognition, how it's measured, and the environmental conditions that amplify it, this module turns to a critical question. How do these biases translate into measurable differences in the care patients actually receive? In the slides ahead, we'll examine the evidence across 4 major domains of clinical impact: diagnostic error and diagnostic equity, pain assessment and treatment disparities, treatment decisions and referral patterns, and patient-provider communication with its downstream effects on trust and health outcomes. The research in each of these areas is extensive, and the patterns are remarkably consistent. Let's begin with diagnostic error and diagnostic equity. The relationship between implicit bias and diagnostic error operates through multiple cognitive mechanisms. A 2025 New England Journal of Medicine review described a framework linking stereotypes, false assumptions, and inattention to systemic factors to diagnostic errors with cascading consequences across communities. Cognitive biases have been associated with approximately 28% of diagnostic errors. And because 70 to 80% of a diagnosis is shaped by the patient's history, biased assumptions during history taking can lead to premature diagnostic closure. That is, settling on a diagnosis before all relevant information has been considered, and inaccurate problem representations, meaning the clinician develops a flawed mental summary of the patient's case. The concept of intergroup time bias provides a direct mechanism linking implicit bias to diagnostic accuracy. A 2024 study of 434 white medical trainees found that trainees invested more time evaluating white versus black male patients, and this biased time investment mediated impacts on diagnostic accuracy, pain perception, and opioid prescriptions. That finding suggests that differential attention, not merely differential attitudes, is a pathway through which implicit bias produces disparate clinical outcomes. Psychiatric misdiagnosis represents one of the most well-documented consequences of diagnostic bias. Black Americans are approximately 2.4 times more likely to be diagnosed with a schizophrenia spectrum disorder compared with white individuals. That disparity is explicitly acknowledged in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, known as the DSM-5TR, as attributable to clinical bias, racism, or discrimination. Stigmatizing language in medical documentation functions as a transmission vector for bias between clinicians. A cross-sectional study of 48,651 admission notes found stigmatizing language in 2.5% of all notes, with notes about non-Hispanic Black patients having a 0.67 percentage point greater probability of containing such language. In a randomized vignette study, exposure to stigmatizing language led to more negative attitudes toward the patient, showing that biased documentation perpetuates biased care across the treatment team. Beyond psychiatric contexts, diagnostic overshadowing, in which a visible patient characteristic such as obesity or disability leads clinicians to attribute symptoms to that characteristic rather than investigating alternative diagnoses, represents another well-documented pathway through which implicit bias produces diagnostic error, particularly in weight and disability bias domains. We turn now to one of the most consistent and persistent findings in the implicit bias literature: racial disparities in pain management. Research has documented that false beliefs about biological differences between racial groups, such as the belief that Black people's skin is thicker or their nerve endings less sensitive, persist among healthcare professionals and are associated with lower pain ratings and less accurate treatment recommendations for Black patients. The American College of Obstetricians and Gynecologists, or ACOG, issued a 2024 committee statement tracing these beliefs to the enslavement era, noting that they persist today, affecting clinical treatment courses. An analysis of National Hospital Ambulatory Medical Care Survey data, spanning 1999 to 2020, covering a population-weighted estimate of more than 42 million annual emergency department pain visits, found that white patients were roughly 26% more likely to receive opioid prescriptions than Black patients, 40% versus 32%, a disparity that was statistically reliable and consistent across the dataset. Trend analysis across the full observation period found no evidence of meaningful change in the magnitude of these disparities across the entire 22-year study period. That's a remarkable persistence, despite growing awareness of racial bias in pain care. These disparities persist across every clinical setting in which they've been examined. In emergency departments, Black patients were roughly 45% less likely to receive opioids than white patients after accounting for pain severity, insurance, and clinical factors. In inpatient settings at a major academic medical center during 2021 to 2022, racial and ethnic minority patients received significantly fewer opioids. Specifically, Asian patients received 61.3 fewer morphine milligram equivalents per day, Black patients received 44.9 fewer, Latino patients received 48.8 fewer, Native American and Alaska Native patients received 80.4 fewer, and Native Hawaiian and Pacific Islander patients received 72.9 fewer morphine milligram equivalents per day compared to white patients. The magnitude of these differences is striking and consistent across every minority group studied. These disparities were amplified even further among patients with co-occurring substance use disorders. In that subgroup, Asian patients received 124.4 fewer morphine milligram equivalents per day, Black patients received 68.7 fewer, and Latino patients received 110.8 fewer. That suggests the intersection of racial bias and substance use stigma compounds treatment inequity. The pattern extends to specific insurance populations as well. Among Medicare beneficiaries with disability across 310 health systems, Black patients received 36% fewer morphine milligram equivalents annually, with 75% of health systems showing clinically meaningful differences of 15% or greater. This isn't a problem isolated to a few institutions. 3/4 of health systems studied demonstrated substantial racial gaps in pain treatment. The misapplication of prescribing guidelines has compounded these disparities in specific populations. Sickle cell disease provides a particularly troubling example. Despite disease-specific guidelines recommending opioids for vaso-occlusive crises, which are episodes of severe pain caused by blocked blood flow, in sickle cell disease, a condition predominantly affecting African Americans, the 2016 Centers for Disease Control and Prevention opioid guideline was misapplied to these patients. This increased barriers to opioid access, stigmatization, and physician scrutiny of dosage for a patient population with a legitimate, well-documented need for pain management. Recognizing this harm, the CDC 2022 Clinical Practice Guideline for Prescribing Opioids for Pain explicitly acknowledges that differentially untreated or undertreated pain, as a result of clinician biases, persists and demands immediate and sustained attention and action. The updated guideline also notes that safeguards in opioid prescribing are disproportionately applied to Black patients, who are more likely to have restricted early refills and face opioid discontinuation for evidence of misuse. This acknowledgement from one of the nation's leading public health agencies highlights the severity and systemic nature of racial bias in pain management. Gender disparities in pain care operate through distinct but intersecting mechanisms. A 2026 model reviewing 66 articles conceptualizes gender biases in pain care as contextual, arising from the interaction between provider stereotypes, patient characteristics, and clinical context rather than from fixed provider attitudes alone. Research consistently shows that women's pain is more likely to be attributed to psychological factors, women are more likely to be recommended psychological treatment, while men are more likely to receive analgesics, and women are judged as more likely to exaggerate pain. These patterns translate into measurable treatment differences. In a study of 32,676 emergency department patients with undifferentiated abdominal pain, women were prescribed narcotics 17.0% of the time compared to 19.4% for men, a statistically significant difference. A corpus-based discourse analysis, that is, a systematic study of language patterns in real clinical conversations, examined 171 real medical interactions recorded between 2008 and 2020. This analysis revealed that racial and ethnic minorities had significantly lower odds of being prescribed opioids and were less likely to be proactively offered opioids, requiring them to initiate requests for pain medication. The discourse analysis showed patterns of increased scrutiny and hesitance in prescribing to minority patients even when they reported severe pain. Intersectional effects compound these disparities. Patient weight interacts with gender, such that the pain of women across weight categories is attributed more to psychological factors than the pain of men. And gender discrimination itself is independently associated with greater chronic pain interference among women. Pediatric pain disparities mirror adult patterns. In a Pediatric Emergency Care Applied Research Network, or PECARN, registry analysis of 21,069 children with long bone fractures, minority children were less likely to receive opioids. Non-Hispanic African American children were approximately 14% less likely to receive opioids, and Hispanic children showed a similar reduction in likelihood. These children were also roughly 20% less likely to achieve optimal pain reduction, even though they were paradoxically more likely to receive any analgesic at all. Neurobiological evidence from functional magnetic resonance imaging, or fMRI, in an ethnicity and gender balanced sample provides an important scientific anchor for this discussion. The neurologic pain signature, a neuromarker sensitive and specific to nociceptive pain, meaning pain arising from actual or potential tissue damage, mediated painful heat effects on pain reports similarly across ethnicities. This confirms that nociceptive pain processing is comparable across racial groups. Observed differences in pain report were instead driven by interpersonal context, discrimination experiences, and extranociceptive central pain mechanisms, that is, pain processing pathways in the brain, beyond direct tissue damage signaling. This evidence definitively refutes claims of inherent biological differences in pain sensitivity between racial groups. Moving beyond pain management, implicit bias influences treatment decisions more broadly, with documented disparities in specialist referrals, surgical recommendations, rehabilitation access, and weight-based eligibility restrictions that function as institutionalized bias. Let's look at the referral and surgical data. Research has documented differential sorting of patients to specialists by race across all 6 specialties examined in a Medicare claims analysis. Specialist networks for white patients were substantially larger than those for black patients. For example, 330 cardiologists were accessible to white patients versus only 135 for black patients in the same healthcare markets. Surgical recommendation disparities are documented for conditions including glioblastoma, the most aggressive form of primary brain cancer, where black patients were approximately 27% more likely to receive a recommendation against surgical resection, a disparity that was statistically reliable and consistent across the study population. In physical rehabilitation, white patients were 57% more likely to receive physical therapy within 90 days of a new musculoskeletal pain diagnosis compared to black patients, a disparity that was statistically reliable and consistent in a large electronic health record study of more than 52,000 patients. After total knee arthroplasty in a Medicare cohort of nearly 24,000 patients, physical therapy within 90 days was less likely for every minority group studied. Black patients were roughly 19% less likely, Native American patients roughly 42% less likely, Asian patients roughly 50% less likely, and Hispanic patients roughly 56% less likely to receive therapy compared to white patients. These disparities in rehabilitation access are especially relevant for physical therapy, occupational therapy, and nursing professionals. Weight-based treatment restrictions represent a formalized expression of weight bias in clinical decision-making. Body mass index, or BMI-based surgical eligibility restrictions provide a clear example. Surveys of orthopedic surgeons found that approximately half used a BMI cutoff of 40 for total joint arthroplasty, that is, joint replacement surgery. Among top U.S. orthopedic institutions, 54% applied preoperative BMI cutoffs. The evidence against rigid cutoffs is compelling. A study of more than 27,000 total joint arthroplasties found that the probability that a BMI of 40 or greater correctly predicted a major complication was only about 7%. To put that in practical terms, for every patient who would have avoided a complication by being denied surgery, nearly 14 patients would have been denied a complication-free procedure. Current American College of Rheumatology and American Association of Hip and Knee Surgeons, or ACR-AHKS, guidelines conditionally recommend proceeding to arthroplasty without delaying for weight reduction for patients with a BMI of 35 to 39, noting that the use of absolute BMI or rigid thresholds is discouraged, and that pain and function improvements are similar regardless of obesity class. Despite these guidelines, healthcare professionals commonly describe patients with obesity as lazy, non-compliant, and lacking willpower, and physicians spend less time in appointments and provide less education to patients with higher body weight. Cardiovascular care disparities provide further evidence of how weight bias translates into treatment inequities. Patients with Class 3 obesity had the lowest adjusted odds for cardiac catheterization, percutaneous coronary intervention, which refers to catheter-based procedures to open blocked arteries, and coronary artery bypass grafting, meaning the surgical rerouting of blood flow around blockages compared to overweight patients. This disparity exists despite their high coronary heart disease risk, and has been described as similar to that seen in persons of non-white race and in women. Technical challenges in the catheterization laboratory for patients with obesity, including suboptimal radiographic visualization, vascular access difficulties, and table weight limits, may contribute to clinician hesitancy. However, patients who did receive interventions had improved mortality across all BMI classes, suggesting the disparity leads to worse outcomes rather than reflecting appropriate clinical caution. In diabetes management, similar patterns emerge. A systematic review found that patients with obesity were susceptible to less frequent pharmacological treatment intensification, and approximately 50% of people with obesity and type 2 diabetes report experiencing weight bias in healthcare settings. The American Diabetes Association, or ADA, Standards of Care, explicitly acknowledges that fat bias is prevalent among healthcare professionals and strongly encourages awareness of implicit and explicit weight-biased attitudes. We turn now to the impact of implicit bias on patient-provider communication, which is one of the most consistently documented findings in the literature. All 7 studies examining real-world patient-provider interactions in a major systematic review found that providers with stronger implicit bias demonstrated poorer communication quality. Physicians with higher racial implicit association test scores show more verbal dominance, less supportive communication, shorter interactions, and increased use of words reflecting social dominance and anxiety when caring for Black compared with white patients. In a study of 18 oncologists and 112 Black patients, higher implicit bias was associated with lower patient trust, less patient-centered communication, and patients having more difficulty remembering interaction contents. Among 134 clinicians and 2,908 patients, those with greater implicit bias were rated lower in patient-centered care by their Black patients compared with white patients. A landmark study using the Rotor Interaction Analysis System found that primary care physicians demonstrated roughly 35% less emotional rapport with overweight patients, a finding that was statistically reliable, and roughly 31% less emotional rapport with obese patients. Again, a reliable and consistent finding compared to normal weight patients. There were no differences in biomedical or psychosocial communication, suggesting that the deficit was specifically in the relational domain, the warmth and emotional connection that form the foundation of therapeutic relationships. The downstream consequences of impaired communication are clinically significant. Patient-clinician communication has been found to mediate approximately 19 to 20% of the association between perceived discrimination and delayed care in a study of more than 25,000 participants from the All of Us research program. Patients who report discrimination in medical settings have more than twice the likelihood of reporting fair or poor quality of care, a finding that was statistically reliable and consistent, and are significantly more likely to report insufficient time with the physician and inadequate involvement in decision-making. During the COVID-19 pandemic, experienced racial discrimination was strongly associated with delaying or foregoing care among non-Hispanic Black individuals, who were more than 4 times as likely to delay or forego care when they had experienced discrimination, and among Hispanic individuals, who were nearly 4 times as likely, both findings statistically reliable and robust. Provider implicit bias has been consistently negatively associated with patient trust among racial and ethnic minority patients, a pattern confirmed across oncology, primary care, and other clinical settings. The relationship between implicit bias and treatment adherence operates through indirect pathways. Physicians with higher implicit bias have larger talk time ratios, meaning they talk more relative to their patients, and less balanced conversations are associated with less subsequent patient adherence. Weight stigma drives healthcare avoidance independent of BMI. In multinational research across 6 countries involving 13,996 participants, among those reporting a weight stigma history, which was 56 to 61% of participants, 2/3 experienced weight stigma from doctors. Higher internalized weight bias was associated with greater healthcare avoidance, lower frequency of routine checkups, and lower perceived quality of care across all 6 countries studied. Approximately 40 to 50% of U.S. adults with overweight or obesity have internalized weight bias, and this internalized stigma is independently associated with healthcare avoidance even after controlling for BMI. Effective strategies for reducing weight stigma in healthcare include using person-first language, avoiding assumptions about health based on body size, addressing the patient's presenting concern before discussing weight, and ensuring that clinical environments accommodate patients of all body sizes. The clinical disparities we've documented raise a practical question. What can clinicians do in the moment to counteract the influence of implicit bias on patient interactions? This section examines 2 complementary cultural frameworks, cultural competence and cultural humility, along with several evidence-based communication techniques that have been shown to reduce the effects of bias in real clinical encounters. The goal is to move from understanding the problem to developing concrete, actionable skills. 2 complementary frameworks guide the profession's approach to equitable cross-cultural care. Cultural competence, defined by Cross and colleagues in 1989, refers to a set of congruent behaviors, attitudes, and policies that enable effective work in cross-cultural situations. Its core components include cultural awareness, cultural knowledge, and cultural skills, an orientation toward learning about patient populations' health beliefs, communication patterns, and expressions of illness. Cultural humility, introduced by Tervalon and Murray Garcia in 1998, represents a different but complementary orientation. It's a lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the patient-clinician dynamic, and to developing mutually beneficial and non-paternalistic partnerships with communities. Rather than studying the other, cultural humility begins with examining one's own beliefs and cultural identities. The distinction between these frameworks carries practical implications for clinical encounters. Cultural competence is knowledge-based, implies achievable mastery, and positions the clinician as the cultural expert who has learned about the patient's background. Cultural humility is attitude and behavior-based, is never fully achieved, and positions the patient as the expert on their own experience. Each approach carries its own risks. Cultural competence's primary risk is stereotyping, applying learned group-level knowledge to individual patients in ways that may not fit. Cultural humility's risk is placing undue burden on patients to educate clinicians about their experiences. To illustrate the difference in practice, a culturally competent clinician might recall that, in this culture, family elders typically make medical decisions and tailor the encounter accordingly. A culturally humble clinician, by contrast, explicitly asks, "How would you like to be involved in this decision? Is there anyone else you'd like to include?" The first approach draws on learned cultural knowledge, while the second invites the patient to define their own preferences. The evidence base for cultural competence training shows consistent improvement in provider knowledge, attitudes, and skills, but the most rigorous assessments reveal limited impact on patient outcomes. A Cochrane systematic review of 5 randomized controlled trials involving 337 healthcare professionals and 8,400 patients found no evidence of effect on clinical treatment outcomes and only low-quality evidence of improved patient engagement. Cultural competence has been critiqued for promoting overly reductionist, simplistic, and static depictions of culture, often reduced to race and ethnicity, and for implying that culture is something the clinician can master rather than a dynamic, intersectional, and deeply individual experience. Cultural humility, by contrast, shows stronger associations with therapeutic alliance and patient outcomes in clinical settings. Research across multiple studies has found that client perceptions of clinician cultural humility are positively associated with stronger working alliance, improvement in therapy, and fewer racial microaggressions in clinical encounters. Among 2,212 racial and ethnic minority clients, client-perceived cultural humility was associated with fewer microaggressions experienced in counseling. Longitudinal data showed that within client time periods characterized by higher perceived cultural humility were associated with stronger next session working alliance and significant increases in client functioning over time. In medical settings, clinician humility has been found to positively predict patient satisfaction, trust, and self-reported health status above and beyond patient, clinician, and visit characteristics. A simulation-based health equity curriculum for 216 first-year residents showed statistically significant improvement in cultural humility scores and confidence in addressing bias and social determinants of health, with improvements sustained at 3 to 6 months and approximately 70% reporting impact on subsequent patient interactions. Professional societies have increasingly shifted toward cultural humility or toward recognizing both frameworks as complementary. Earlier positions from the 2000s endorsed cultural competence, while more recent guidelines from 2019 to 2025 increasingly favor cultural humility or both. The practical synthesis is this: cultural competence provides the knowledge base, understanding health disparities, recognizing cultural expressions of illness, providing language concordant care, while cultural humility provides the relational stance, self-reflection, power sharing, and a posture of curiosity that prevents that knowledge from calcifying into stereotypes. Multiple structured communication frameworks have been developed to reduce the effects of implicit bias during clinical encounters. These approaches emphasize concrete, learnable behaviors rather than relying solely on attitudinal change. Let's walk through several of the most evidence-supported frameworks. The RELATE framework, which stands for respect, empathize, listen, ask, talk, engage, serves as both a measurement tool and a practical clinical framework for bias-mitigating communication. As introduced in Module 1, it represents the first rigorously validated tool for evaluating these skills. Performance data from the 123 trainee evaluation revealed that while most trainees demonstrated foundational behaviors, 85% introduced themselves appropriately, 87% maintained open posture, and 85% began with open-ended questions, the items with the greatest opportunity for improvement were exploring reasons and barriers for non-adherence, including social and cultural reasons, where only 65% performed adequately, and assessing patient understanding of the final care plan, where 70% performed adequately. These findings point to specific skills that deserve focused attention in clinical training. Verbal procedures for repairing bias provide clinicians with personalized, verbatim statements for restoring rapport when implicit bias has affected an encounter. These were introduced in Module 1 as a complement to behavioral assessment. Examples include statements like, "I realize I may not have fully heard what you were telling me. Can we go back to that?" And, "I want to make sure I'm giving you the same thorough attention I give every patient." Research on methods for developing these verbal procedures found that role-play methods produced significantly more helpful elements than audience response methods, a difference that was statistically robust and almost certainly not due to chance, suggesting that practicing these statements in simulated encounters is more effective than simply generating them in a classroom setting. The Presence 5 for Racial Justice Framework provides structure for fostering connection across difference through 5 practices. Prepare with intention, listen intently and completely, agree on what matters most, connect with the patient's story, and explore emotional cues. The adaptation for racial justice adds an important preparatory step, reflecting on one's own identity, power dynamics, and potential biases relevant to the specific patient before entering the room. The NURSE acronym provides a structured approach to responding to patient emotions. NURSE stands for naming, understanding, respecting, supporting, and exploring. Naming means identifying the emotion the patient is experiencing, for example, saying, "This seems overwhelming." Understanding involves validation. "I can only imagine how difficult this must be." Respecting acknowledges the patient's effort. "I can see how hard you've been working to manage this." Supporting expresses partnership. "We'll work through this together." And exploring invites further disclosure. "Can you tell me more about that?" Each of these components creates space for the patient to feel heard and validated. The pause framework provides a complementary structured approach to disrupting bias during clinical encounters by creating deliberate pauses for reflection before critical decisions. Pause stands for pay attention, acknowledge interpretations, understand your perspective, seek different perspectives, and examine your options. This framework is designed to interrupt automatic processing and engage more deliberative reasoning, essentially creating a moment for System 2 to override System 1 before a potentially biased decision is made. Teachback is another powerful communication tool with a strong evidence base. It's demonstrated effectiveness in 19 of 20 studies and particularly benefits patients with inadequate health literacy, who are more than twice as likely to report feeling listened to and nearly 2.5 times as likely to feel confident acting on clinical recommendations. The technique sounds like this. "I want to make sure I explain this clearly. Can you tell me in your own words what we discussed?" This simple reframing shifts the responsibility for communication success from the patient to the clinician. It's the clinician's job to explain clearly, not the patient's job to understand perfectly. Nonverbal behaviors also carry significant weight in cross-cultural encounters. Sitting down during patient interactions increases patient estimates of visit length and perception of being listened to across multiple randomized trials. Open body posture correlates with higher patient ratings of warmth across physician and patient racial and ethnic backgrounds. Avoiding interruption is especially important. Research shows that physicians interrupt within an average of just 11 seconds, and allowing uninterrupted patient openings doesn't substantially extend visit time. Empathic nonverbal behavior increases ratings of both warmth and competence simultaneously with no trade-off in medical contexts. In other words, appearing warm doesn't come at the cost of appearing competent, a concern some clinicians may have. The ability to recognize when implicit bias may be affecting an interaction in real time during the encounter is a learnable skill that deserves specific attention. There are specific cues to monitor. These include patients becoming quieter, more guarded, or less forthcoming during the encounter. Watch for shifts in body language, such as crossing arms or avoiding eye contact. Also notice if patients appear to be managing the clinician's perception of them, which can be a sign of stereotype threat activation when a person becomes concerned about confirming a negative stereotype about their group. When such cues are detected, the recommended response sequence is to pause, check in with something like, "I notice you seem uncomfortable. Is there something I can do differently?" Acknowledge the patient's experience and re-partner in the clinical relationship. There's an important distinction here between perspective taking and perspective believing. Perspective believing, acknowledging that lived experiences vary, and therefore perspectives will vary, is recommended over simple perspective taking as a more effective approach to building trust with patients who encounter bias and discrimination. Rather than merely imagining what it would be like to be in someone else's position, perspective believing accepts the validity of another person's experience as reported, even when it differs from your own. Patient activation represents a powerful and evidence-based strategy for disrupting the expression of implicit bias during clinical encounters. A landmark study published in the Proceedings of the National Academy of Sciences trained black and white standardized patients to be either activated, meaning they asked questions and self-advocated, or typical during appointments with unsuspecting oncologists and primary care physicians. The results were striking. Physicians' implicit association. Tests measured implicit racial bias predicted racially biased interpersonal treatment among typical patients, but not among activated patients. This was confirmed by ratings from both standardized patients and independent blinded coders. The finding shows that patient activation can effectively neutralize the behavioral expression of provider implicit bias during clinical encounters. Clinicians can encourage this activation through a subtle but important linguistic shift. Instead of asking, "Do you have any questions?" which implies the patient might not have questions, clinicians should ask, "What questions do you have?" This phrasing presupposes that the patient has questions, creating an expectation that asking questions is normal and welcome. It's a small change in wording that can meaningfully shift the dynamic of the encounter. Shared decision-making offers another structured approach to reducing bias in treatment decisions. A scientific statement from the American Heart Association examined shared decision-making interventions with culturally diverse populations and found moderate positive effects for disadvantaged patients. Cultural tailoring matters enormously here. Culturally tailored shared decision-making interventions were substantially more effective than non-tailored approaches, with 67% showing improvement compared to only 33% without cultural tailoring. One especially illuminating finding involved a patient decision aid for joint replacement. When the same decision aid was implemented across populations, it decreased arthroplasty utilization in a largely white population, but increased arthroplasty among Black patients with historically low rates. This suggests that shared decision-making can correct both overuse and underuse disparities by providing patients with the information and agency to make choices aligned with their actual preferences. Key factors that support effective shared decision-making among racially and ethnically diverse populations include clear, honest, and humanistic communication, patients having the ability to ask questions, and cultural concordance or competence between clinician and patient. Building and maintaining trust is the thread that connects all of the communication strategies we've discussed. Research based on a nationally representative survey of 6,517 U.S. adults, supplemented by 40 qualitative interviews, identified 3 domains that patients prioritize when building trust with healthcare providers. The first is communicating effectively, listening and providing detailed explanations. The second is caring, treating patients as individuals rather than diagnostic categories. The third is demonstrating competence, being knowledgeable and thorough. These 3 domains align directly with the Relate framework and the cultural humility orientation, suggesting convergence across evidence bases on what constitutes equitable clinical communication. Trust isn't a static attribute but a dynamic process that can be rebuilt even after rupture. Cultural humility frameworks emphasize repairing cultural ruptures when bias or discrimination occurs, by exploring the patient's experience, acknowledging the validity of their concerns, and actively seeking to repair the breach. That's a hopeful finding. Even when the therapeutic relationship is damaged by bias, intentional effort using these evidence-based strategies can restore trust and move the clinical encounter forward. Communication skills address the interpersonal dimension of bias, but lasting change also requires broader strategies at the individual, organizational, and systemic levels. This module examines the evidence on what works and what doesn't for reducing the impact of implicit bias on patient care. Let's begin with individual mitigation strategies. Evidence-based individual strategies for reducing the influence of implicit bias on clinical behavior fall along a spectrum of strength, from awareness raising to skills-based intervention. One of the most consistently recommended strategies is individuation, which means deliberately focusing on individual patient characteristics rather than group membership. The Relate rating scale explicitly incorporates individuation as a core domain, defining it as preventing stereotypic inferences by obtaining specific information about group members. The practical application is straightforward. Before and during each patient encounter, consciously seek patient-specific information, including their goals, preferences, living situation, support systems, and concerns, in order to create an individuated representation that displaces group-based stereotypes. Research using functional neuroimaging has shown that national stereotypes didn't affect empathic response when individuating information was provided, confirming that individuation works at the level of neural processing, not merely self-report. Another well-supported individual strategy is mindfulness and self-regulation. A meta-analysis of 70 samples found a meaningful reduction in bias outcomes for mindfulness-based interventions, with the overall reduction falling in the medium range, a reliable improvement that was consistent across the body of research and almost certainly not due to chance. This suggests that mindfulness practice can meaningfully reduce bias activation. The proposed mechanisms by which mindfulness achieves this include reducing the likelihood of bias activation in the first place, increasing awareness and the ability to control responses once bias has been activated, increasing self-compassion, and reducing cognitive load from stress and burnout. Mindfulness may also avoid the resistance some providers feel when directly confronted with evidence of racism. However, systematic review evidence indicates that brief mindfulness interventions of 4 hours or less for healthcare providers improved provider well-being in 9 of 14 studies, but found no effect on provider behavior. This suggests that mindfulness may be necessary, but not sufficient, without complementary skills training. The 4-hour threshold appears to be an important benchmark. Mindfulness interventions below that duration may help clinicians feel better, but don't, on their own, change what clinicians actually do in clinical encounters. A third promising individual strategy involves implementation intentions, also known as if-then plans. An example would be, if I notice I am making assumptions about a patient's pain based on their appearance, then I will ask open-ended questions about their pain experience. These represent a promising metacognitive strategy, meaning a technique for consciously directing one's own thought processes, that has shown effectiveness at reducing both stereotype activation and stereotype application, even under conditions of cognitive load. Research has confirmed that proactive control, which means engaging regulatory strategies in advance of biasing influences rather than merely reacting to them after the fact, can eliminate expressions of bias on implicit assessments across 4 experiments. Neither proactive control nor implementation intentions have been tested in actual clinical encounters to date, but their effectiveness under cognitive load makes them theoretically well-suited to healthcare settings, where time pressure, fatigue, and high patient volumes are the norm. Now let's consider the role of awareness. The central finding across multiple reviews is that raising awareness of implicit bias can shift attitudes and establish egalitarian goals, but these changes alone aren't sustained and don't reliably translate to behavior change. That's a critical point. Awareness is necessary, but insufficient. There are important risks associated with awareness-only approaches. Awareness of stereotype prevalence can paradoxically normalize stereotyping by conveying the message that everyone does it. Stereotype suppression, which means telling people to avoid stereotyping, can actually worsen implicit biases through what's called a rebound effect, in which suppressed thoughts become hyper-accessible. Suppression depletes self-regulatory resources and can produce rebound effects not just for the suppressed stereotype, but for targets from any social category. Mindfulness-based approaches may avoid this rebound effect by promoting non-judgmental awareness rather than suppression. Rather than telling yourself not to think about stereotypes, mindfulness encourages noticing those thoughts without judgment and letting them pass, which avoids the cognitive depletion that suppression causes. These risks show why awareness must be coupled with skills-based training and organizational support rather than treated as an end in itself. Moving on to organizational and systemic strategies, we begin with standardized protocols and safety bundles. Implicit bias exerts its greatest influence at points of clinical discretion, where subjective judgment, time pressure, and cognitive load converge. Standardized protocols reduce this discretionary space, and the evidence for their effectiveness is compelling. The Louisiana Perinatal Quality Collaborative's statewide implementation of maternal safety bundles, which are coordinated sets of evidence-based practices implemented together, reduced non-transfusion severe maternal morbidity, meaning life-threatening complications during delivery excluding transfusions, by 44% overall. Among non-Hispanic Black individuals, the decline was even more dramatic at 54.7%. The Black-white disparity ratio narrowed from 2.2 to 0.9, effectively eliminating the racial gap. An order-set-driven sepsis initiative across 8,151 patients found that Black race was associated with meaningfully higher mortality risk before the intervention, roughly 41% higher, a finding that was statistically significant. After standardized protocols were implemented, this racial association with mortality was eliminated entirely. Research on racial bias in emergency department triage provides further evidence. Racial bias is more pronounced for subjective chief complaints such as chest pain, dyspnea, and pain, but it's absent for protocolized conditions such as stroke and ST elevation myocardial infarction, known as STEMI. This directly shows that explicit protocols reduce racial disparities in clinical decision-making. Another powerful systems-level strategy is removing race from clinical algorithms. The most impactful systems-level equity intervention in recent years has been the removal of race-based corrections from clinical algorithms. The mandate for race-neutral estimated glomerular filtration rate, or EGFR, calculation in July 2022 resulted in modifications adding a median 1.7 years of accrued transplant wait time for more than 21,000 Black kidney transplant candidates. To put that in perspective, that amounts to a total of 51,061 person years of additional access to the transplant waiting list, representing an enormous correction of a structural inequity that had been built directly into the clinical algorithm. However, algorithmic interventions aren't uniformly beneficial. A systematic review of 63 studies found mixed evidence indicating that clinical algorithms can reduce, perpetuate, or worsen racial disparities depending on their design and implementation. This means that removing race from algorithms must be done thoughtfully, with attention to whether the algorithm is using race as a proxy for biological differences that don't exist, versus as a proxy for social determinants that should be measured directly. The evidence on workforce diversity and concordance provides a compelling case for its protective role. A study of 1.8 million Florida hospital births found that newborn physician racial concordance was associated with significantly reduced mortality for Black infants, particularly during more challenging births. In a cohort study of 1,618 U.S. counties, every 10% increase in county-level Black primary care physician representation was associated with roughly 30 additional days of life expectancy for Black individuals, a finding that was statistically reliable and robust. A randomized trial found that Black men assigned to Black physicians were more likely to receive preventive health screenings, with increases of 49% for diabetes testing, 71% for lipid screening, and 56% for influenza vaccination. These aren't subtle effects. They represent substantial, clinically meaningful differences in whether patients receive basic preventive care. Despite these findings, pipeline challenges persist. Following the 2023 Supreme Court affirmative action ruling, Maryland matriculation declined by 11.6% for Black students and 10.8% for Hispanic students between the 2023 to 2024 and 2024 to 2025 academic years. That's a concerning trend that may undermine future workforce diversity at precisely the moment when its benefits are most clearly documented. Let's now turn to a critical topic, training design, and specifically what works and what doesn't. This distinction matters because the quality of existing implicit bias training programs is, frankly, alarming. A systematic review of 77 implicit bias training programs found significant quality problems. Trainings diverged from current social psychology literature in 10 to 67.5% of their design elements. 99.9% of programs lacked internal validity, meaning they didn't have rigorous cause and effect study designs. 93.5% lacked face validity, meaning they weren't aligned with their own stated learning goals. And 100% lacked external validity, meaning none had demonstrated applicability to real clinical settings. This gap between what the evidence supports and what organizations actually implement represents a fundamental challenge for the field. So what does work? Multi-session skills-based training grounded in social psychology and behavior change theory shows the strongest effects. The Break the Bias Habit Workshop is one of the best studied examples. This was a multi-site cluster randomized controlled trial involving 8,657 faculty across 19 departments of medicine. The study found statistically significant increases in both awareness and self-reported action at 3 months, improvements that were reliably detected and unlikely to be explained by chance. The workshop didn't produce effects on division climate or burnout. However, at 2-year follow-up of the original prejudice habit-breaking intervention, participants were more likely to publicly object to racial stereotyping on an online forum, suggesting enduring behavioral change even without sustained changes in IAT scores. The iDream program provides the strongest evidence of objectively measured behavior change. This program involved 1,811 clinicians and used simulation-based training. After training, telephone interpreter service use increased by approximately 261 calls per month, a large and statistically robust increase that was almost certainly not due to chance. Confidence in responding to bias events increased from 45% to 73%, with effects sustained at 3 months. The iDream results are especially noteworthy because they show a measurable change in actual clinical behavior, not just attitudes or self-report. Now let's look at what doesn't work. Mandatory standalone diversity training has been associated with psychological reactance, which refers to negative emotional responses that fuel increased denial that social inequity is a problem. Across 4 pre-registered experiments, meaning studies with methods documented before data collection began, researchers found that mandatory, as opposed to optional diversity training, engendered reactance that is unique to mandatory diversity training. This reactance didn't occur with mandatory training on other topics. The effect is moderated by political orientation, with more conservative participants showing stronger reactance-induced denial. Awareness-only training without skills development has no demonstrated efficacy for behavior change and may actually produce avoidant behaviors. Perhaps most troubling is what researchers have called the presumed fair effect. The mere presence of organizational diversity structures, including diversity training, can cause high-status group members to perceive organizations as procedurally fairer, even when clear evidence of discrimination exists. This creates a dangerous dynamic in which the existence of training programs reduces sensitivity to discrimination and may make individuals react more harshly toward those who claim discrimination. In short, training can become organizational cover that makes the problem worse, rather than better when it's poorly designed or mandated without a broader strategy. What sustains the effects of training over time? The evidence points to active strategy use, concern about discrimination, spaced reflection, and complementary organizational initiatives as the factors that maintain long-term training effects. Knowledge and awareness gains are the most reliably improved and most durable outcomes. Awareness gains from a single workshop have been shown to be retained at 1 year with no significant decay. Clinical behavior, however, remains the least studied and least demonstrated outcome. Only 34.5% of studies in a recent systematic review assessed actual provider behavior, and only 6.3% evaluated patient outcomes. That's a striking gap. The vast majority of studies measure what clinicians think or know, not what clinicians do. Perhaps most concerning, no studies have tested booster sessions or spaced repetition protocols against a no reinforcement control for behavioral outcomes. This represents one of the most critical evidence gaps in the field. We know from learning science that spaced practice outperforms mass practice for virtually every type of learning. Yet the implicit bias training literature hasn't tested whether periodic refresher sessions maintain the behavioral effects of initial training. Moving now to organizational accountability, we'll examine how institutions translate the evidence on implicit bias mitigation into requirements and measurement structures that create sustained pressure for equitable care. One of the most significant developments in this area is the Joint Commission's National Patient Safety Goal 16. Effective July 1, 2023, and updated in December 2025, the Joint Commission elevated health equity to National Patient Safety Goal 16. This requires accredited organizations to meet 6 key requirements: designate a health equity leader, assess patients' health-related social needs, stratify quality and safety data by socio-demographic characteristics, develop written action plans addressing identified disparities, act when goals aren't achieved, and annually report progress to stakeholders. This framing of healthcare disparities as analogous to other patient safety events requiring root cause analysis represents a fundamental shift in how organizations are expected to approach equity. It means that a racial disparity in pain management, for example, should receive the same systematic investigation and corrective action as a medication error or a hospital-acquired infection. Financial accountability has also entered the picture through the CMS Health Equity Adjustment. Beginning in fiscal year 2026, the Hospital Value-Based Purchasing Program includes a health equity adjustment that gives additional points to hospitals with more dual-eligible patients, meaning individuals enrolled in both Medicare and Medicaid, which typically indicates low income when those hospitals are providing high-quality care. Analysis of 2,676 hospitals found that this adjustment would reclassify 9.9% of hospitals from penalties to bonuses. Safety net hospitals experienced the largest net positive changes at $29.0 million, and high-proportion Black hospitals would gain $15.5 million collectively. This adjustment was specifically designed to address what's been called the reverse Robin Hood effect, whereby existing value-based programs disproportionately penalize hospitals serving disadvantaged populations. The hospitals that serve the most vulnerable patients were being financially punished under the old system, and the health equity adjustment begins to correct that structural inequity. Equity dashboards and stratified reporting represent another important organizational tool. A Lancet digital health evaluation of all published disparity dashboards found that they can highlight essential disparities and guide targeted quality improvement efforts. However, the evaluation also noted that unintended consequences are possible and that linked action plans are necessary for dashboards to have a real impact. A dashboard that reveals a disparity but isn't connected to a plan for addressing it may simply document inequity without driving change. A national survey of 27 U.S. health systems found significant variation in equity measurement maturity, with only 14.8% having 3 or more years of experience with equity measurement. Race and ethnicity was the most commonly used demographic filter. The first published interactive equity lens integrated into an institutional quality scorecard covered 82 quality measures with stratification by gender, age, race, ethnicity, language, zip code, and payer. This kind of integrated approach allows organizations to see where disparities exist across a wide range of clinical outcomes. 2 final topics round out our discussion of organizational accountability. First, equity-focused quality improvement has demonstrated clear advantages over general quality improvement. Studies with disparity-focused objectives reduce disparities 85% of the time, compared to only 33% for general quality improvement initiatives. General quality improvement without an explicit equity focus may actually widen disparities through what are called intervention-generated inequalities, which occur when populations with better baseline outcomes have greater uptake of the improvement, leaving disadvantaged populations further behind. The Montefiore Equity Toolkit provides a practical example of how to embed equity into quality improvement. This toolkit integrates health equity considerations into existing Institute for Healthcare Improvement quality improvement tools at every step. After implementation, the proportion of quality improvement projects incorporating equity increased from 22.9% to 88.9%. Second, the measurement framework proposed by Golden and Powell recommends a tiered approach. This framework progresses from structural metrics such as organizational readiness in years 1 to 2, through process metrics such as implementation fidelity on an ongoing basis, to outcome metrics measuring clinical impact annually, and ultimately to payment accountability through mechanisms such as the CMS Health Equity Adjustment. This approach emphasizes that accurate collection of race, ethnicity, and language data based on patient self-report is the foundational prerequisite for all equity measurement. This approach emphasizes that accurate collection of race, ethnicity, and language data based on patient self-report is the foundational prerequisite for all equity measurement. However, screening adoption remains inconsistent. In one national network of more than 100 community health centers, only 2% of patients with visits had documented social determinants screening. This gap represents both the central challenge and the most actionable opportunity in equity measurement. Every clinician who consistently collects and documents patient-reported race, ethnicity, and language data strengthens the foundation that makes every downstream strategy possible, from the Montefiore-style integration of equity into quality improvement, to tiered measurement, to payment accountability. The frameworks exist. The tools are validated. What remains is the disciplined, day-to-day clinical practice of capturing the data that makes equity measurable, and therefore improvable. Thank you for completing this course. We will now review the exam questions to solidify your understanding. Question 1. According to dual process theory, which type of cognitive processing is most associated with the activation of implicit bias during clinical encounters? The correct answer is C, System 1 processing, which is fast and automatic. Rationale. Dual process theory distinguishes between System 1, which is fast and automatic, and System 2, which is slow and deliberative. Implicit biases are activated through System 1 processing, which draws on learned associations and heuristics. Under conditions that degrade System 2 capacity, such as cognitive load and time pressure, clinicians rely more heavily on System 1, increasing the likelihood that implicit stereotypes will influence judgment. Question 2. What did research find about the likelihood of white patients receiving physical therapy compared to black patients after a new musculoskeletal pain diagnosis? The correct answer is A. White patients were 57% more likely to receive physical therapy within 90 days compared to black patients. Rationale. In a large electronic health record study of more than 52,000 patients, white patients were 57% more likely to receive physical therapy within 90 days of a new musculoskeletal pain diagnosis compared to black patients. Additionally, after total knee arthroplasty in a Medicare cohort, physical therapy within 90 days was less likely for every minority group studied. Question 3. A resident physician who has been managing a heavy patient caseload reports increasing emotional detachment from patients. Based on the burnout research reviewed in this course, what would this pattern of depersonalization predict about the physician's implicit bias levels? The correct answer is D. Each unit increase in depersonalization is associated with a measurable increase in implicit racial bias, demonstrating a dose-response pattern. Rationale. Burnout and emotional exhaustion have an independent dose-response relationship with implicit racial bias among resident physicians. Each unit increase in depersonalization was associated with a measurable increase in implicit racial bias, a finding that held consistently across the sample. Self-reported fatigue and busyness were not independently associated with implicit association test score changes. Rather, objective environmental demands matter more than clinicians' self-assessment of their cognitive state. Question 4. According to the analysis of National Hospital Ambulatory Medical Care Survey data spanning 1999 to 2020, what was the finding regarding racial disparities in opioid prescribing in emergency departments? The correct answer is B. White patients were roughly 26% more likely to receive opioid prescriptions than black patients, with no evidence of meaningful change over the study period. Rationale. A population-weighted analysis of more than 42 million annual emergency department pain visits found that white patients were roughly 26% more likely to receive opioid prescriptions than black patients, 40% versus 32%. Trend analysis across the full 22-year observation period found no evidence of meaningful change in the magnitude of these disparities, demonstrating remarkable persistence despite growing awareness of racial bias in pain care. Question 5. In an experimental study examining the interaction between cognitive load and implicit bias in opioid prescribing, what pattern was observed among male physicians? The correct answer is A. Under high cognitive load, they were less likely to prescribe opioids for black versus white patients. Rationale. Research demonstrated a three-way interaction between cognitive load, provider gender, and patient race. Under high cognitive load, male physicians were less likely to prescribe opioids for black versus white patients, 12.5% versus 30.0%, while the pattern reversed under low cognitive load. This illustrates that bias emerges from the interaction between cognitive conditions and implicit associations, not from stable racist attitudes. Question 6. Based on the evidence reviewed in this course, how should implicit bias activation among clinicians be understood? The correct answer is C, as a predictable consequence of how the brain processes information under conditions of limited cognitive bandwidth. Rationale. The course emphasizes that implicit bias activation is not a character flaw, but a predictable consequence of how the human brain processes information under conditions of limited cognitive bandwidth. A scoping review of 81 studies confirmed that implicit bias is prevalent across all demographic groups of clinicians, including those who explicitly endorse egalitarian values, and the correlation between self-report measures and implicit measures is typically weak. Question 7. What did the Cochrane Systematic Review find regarding the effect of cultural competence training on patient outcomes? The correct answer is D. There was no evidence of effect on clinical treatment outcomes and only low-quality evidence of improved patient engagement. Rationale. A Cochrane systematic review of 5 randomized controlled trials involving 337 healthcare professionals and 8,400 patients found no evidence of effect on clinical treatment outcomes and only low-quality evidence of improved patient engagement. Cultural competence has been critiqued for promoting overly reductionist depictions of culture and for implying that culture is something the clinician can master. Question 8. How does a culturally humble clinician's approach to a clinical encounter differ from a culturally competent clinician's approach? The correct answer is B. A culturally humble clinician positions the patient as the expert on their own experience and asks about preferences rather than applying group-level assumptions. Rationale. Cultural humility positions the patient as the expert on their own experience, emphasizing self-reflection, power-sharing, and curiosity. In contrast, cultural competence positions the clinician as the cultural expert who applies learned group-level knowledge. The course illustrates this distinction. A culturally competent clinician might recall group-level practices, while a culturally humble clinician explicitly asks the patient how they would like to be involved in decisions. Question 9. What happened to the black-white racial disparity in severe maternal morbidity after the Louisiana Perinatal Quality Collaborative implemented standardized safety bundles? The correct answer is A. The black-white disparity ratio for severe maternal morbidity narrowed from 2.2 to 0.9, effectively eliminating the racial gap. Rationale: the Louisiana Perinatal Quality Collaborative statewide implementation of maternal safety bundles reduced non-transfusion severe maternal morbidity by 44% overall, with an even more dramatic decline of 54.7% among non-Hispanic Black individuals. The black-white disparity ratio narrowed from 2.2 to 0.9, effectively eliminating the racial gap, demonstrating that standardized protocols can reduce both overall harm and racial disparities simultaneously. Question 10. Which individual mitigation strategy uses deliberate focusing on specific patient information to displace group-based stereotypes and has been shown to work at the level of neural processing? The correct answer is C. Individuation, which involves seeking patient-specific characteristics such as goals, preferences, and concerns. Rationale: individuation means deliberately focusing on individual patient characteristics rather than group membership. The Relate rating scale incorporates individuation as a core domain, defining it as preventing stereotypic inferences by obtaining specific information about group members. Research using functional neuroimaging confirmed that national stereotypes did not affect empathic response when individuating information was provided, confirming that individuation works at the level of neural processing. That concludes our review of the exam questions. Thank you for your dedication to providing equitable, evidence-based care. We wish you the best in applying these concepts in your clinical practice.